Dr. Rima Bansal is there, so we'll start with Dr. Hitisha Mittal. And there are two candidates, Hitisha Mittal and Abha Gupta, under Dr. Rima Bansal. अभी से आगे आप बात करें.
Timer. Should I start, sir?
Yes, start.
Good morning, everyone. Saving sight and life in retinoblastoma is of paramount importance for the patient as well as his family. It is the most common. Sorry, it's not working. Morning, everyone.
This is for the mentors.
Timer.
Have they told you
Abhi band
this period of time they have to present for? 4 minutes and 2 minutes of discussion. 1 minute of discussion. Only question answers. The panel comprises of. Okay, and what about
What is the role of mentors?
Okay. Why don't all the mentors come and sit in front? Vaishali, you're a judge, no? Hatu, you come and sit here in the front row. Whoever is a judge, come and sit on the front row. This is all categorization. Okay. So they don't have to be on the dais? They,
Please start.
Good morning, everyone. Saving sight and life in retinoblastoma is of paramount importance not only for the patient but for his entire family. It is the most common ocular malignancy of childhood with an incidence of 1 in 15 to 18,000 live births and an average age of presentation of 18 months. It's a potentially lethal disease due to CNS spread or hematogenous metastasis. However, with adequate treatment, there's a 79% survival rate in countries like India. It occurs due to a mutation in the RB1 gene on chromosome 13, and nearly 30 to 40% of the cases are heritable with the autosomal dominant inheritance pattern. The non-inheritable retinoblastoma have both the hits in the retinal cells postnatally and result in a unilateral retinoblastoma. Now, when do we suspect retinoblastoma in a child? The most common presentations include leukocoria, strabismus, a red painful eye, and poor vision. If left untreated, it can invade the orbit and present with proptosis and a fungating mass. It is important to remember to look for a posterior segment mass lesion in children with congenital cataract to avoid inadvertent entry into the eye. Now, how do we approach? We approach with a detailed history, examination, imaging in the form of B-scan and MRI, then grouping the disease followed by parental counseling regarding the treatment options. Now, the important findings to be noted on EUA include a pseudohypopyon, a subretinal mass or a mass projecting into the vitreous cavity, and seeds at various levels in the eye. All these findings need to be documented properly on an Amsler-Dubois chart so that these patients can be followed up after commencement of the treatment. Now, ultrasound helps us in locating the mass lesion, presence of calcifications, and measuring the dimensions of the tumor, which help us in grouping the disease. MRI orbits and brain.
Timer, you're not starting the timer. No, they're not starting.
MRI orbits help in knowing the extraocular extension, optic nerve infiltration, CNS invasion, and presence of pinealoblastoma. Retinoblastoma lesions are hyperintense on T1 weighted and hypointense on T2 weighted MRIs. Now, based on this, we classify them according to the international classification and plan the further treatment. Our primary motive is to save life, followed by globe salvage, followed by vision salvage. It is important to take care of visual and cosmetic rehabilitation, screening of the siblings, as well as genetic counseling of the parents. Now, there are different treatment modalities present in today's era, which includes chemotherapy, focal therapy, radiotherapy, as well as surgery. Which treatment to give depends on each individual case. The lesser advanced tumors can be treated with a combination of intravenous, focal, or plaque therapies, whereas advanced ones can be treated with intra-arterial and enucleations. Now, intravenous chemotherapy is the current day primary mode of treatment for retinoblastoma, and it may be supplemented with an intravitreal chemotherapy or an intraarterial chemotherapy to achieve higher intraocular drug concentrations. Focal therapies are for smaller tumors as an adjuvant to intravenous therapy. It can be in the form of cryotherapy, a transpupillary thermotherapy, as well as laser photocoagulation. Episcleral plaque therapy is also used as a mean of focal treatment, and post-enucleation eyes can be treated with external beam radiation therapy if histopathology is suggestive of high-risk features. Enucleation is reserved only for advanced intraocular and extraocular retinoblastoma. We should avoid glow perforation intraoperatively and harvest a long optic nerve stump. If histopathology is suggestive of high-risk features, these patients should receive adjuvant treatment post-operatively. So this is how we can save the sight and life in retinoblastoma. This was an 8-year-old child who presented with group D RB. She received treatment in the form of intravitreal and intravenous chemotherapy, and post-treatment there was complete regression of the disease with a visual acuity of 6/16. Thank you, and I would like to thank my mentor, Professor Rima Bansal and AIOS for this opportunity.
What is the role and indication for neoadjuvant therapy?
Sir, if there's, we know there's an extraocular retinoblastoma at presentation, we can give neoadjuvant chemotherapy, reduce the disease burden, and then we can do an enucleation.
Were there any masquerades that you saw?
Ma'am, we have to look for other causes of leukocoria, like it can be Coats disease. It needs to be differentiated from Coats disease. There can be persistent hypoplastic primary vitreous, and it's commonly confused with congenital cataracts. And also we should look for toxocariasis, however not so common in our part of the country. So these should be looked for in every child with leukocoria.
How do you differentiate between Coats disease and retinoblastoma?
Sir, in Coats disease, there is no specific mass lesion, there are no calcifications, and there are telangiectatic vessels up to the peripheral retina, which is not so common in retinoblastoma.
How is it, what is the genetic marking? Genetic marking.
Sir, it is due to RB1 gene mutation, and it's an autosomal dominant pattern, so both children and parents should be screened for it.
What about the status of the other eye?
In the representative case, ma'am, the other eye was group ERB, so she underwent primary enucleation for the other eye elsewhere before presenting to us. She presented to us with the right eye, group DRB, so we managed that eye. The other eye orbit was healthy.
When you give your adjuvant therapies along with cryotherapy, or do you do a laser, or or you give a subtenance injection, what do you manage with?
I'm sorry, I didn't understand.
When you're treating these cases,
Yes, ma'am.
you give them chemotherapy,
Intravenous chemotherapy.
Right.
Yes, ma'am.
you give them adjuvant therapy for the eye in the way of what? Cryotherapy, laser?
Ma'am, if they are anterior to, the tumors are anterior to the equator, we can do a cryotherapy. But if they are posterior and small, less than 4 mm in apical height and less than 2 mm in basal thickness, we can do a transpupillary thermotherapy using infrared radiation, or a laser photocoagulation using green laser, 532
And in the
nanometers.
patients who had vitreous seeds, did you feel there was a regression following your chemotherapy and the adjuvant therapy?
Ma'am, vitreous seeds are the most difficult to treat. They do not respond to intravenous chemotherapy because they do not have a blood supply. So the chemotherapeutic drugs that we are giving systemically, they do not reach the vitreous seeds. So for vitreous seeds, intravitreal chemotherapy has a very high role these days. They respond dramatically to intravitreal chemotherapy.
And how many patients did you give subtenance carboplatin?
It's not commonly practiced in our center. Subtenance, I've not seen.
Thank you.
Thank you so much, ma'am. Thank you, sir.
Okay. A very good morning to all. So I would first like to thank my mentor, Dr. Kasturi Bhattacharya madam, for giving me this opportunity. So we are the teachers today, and we are going to take a class on phakic intraocular lenses. So, starting off, to correct refractive errors, there are three anatomic possibilities: the corneal lens, the crystalline lens, and the space in between them. Now, cornea-directed procedures are related to multiple complications associated with wound healing, a reduced quality of vision, and obvious limitations when it comes to high degrees of ametropia. For refractive lens exchange, there's a loss of natural accommodation, and there's a loss of the crystalline lens barrier, which can cause VR side effects. Now, phakic IOLs forego the risk of corneal ectasias. They preserve the crystalline lens barrier, they're reversible, and they give a better subjective quality of vision. The evolution of phakic IOLs went on from the angle fixated IOLs to the iris claw IOLs, and now the currently in vogue posterior chamber phakic IOLs. So this is the cachette, the last of the angle fixated IOLs. Now this went out of vogue for multiple complications, but mainly because of the endothelial damage they caused and the pupil ovalization. This is the iris fixated IOL. Now this is enclavated onto the mid-peripheral iris stroma with the help of a claw haptic. What these did is they caused iritis, an atrophy of the iris, and loss of the enclavation. So there was a free-floating IOL in the anterior chamber that led to endothelial cell loss, among other complications. Coming to the most important part of today's discussion, the posterior chamber phakic IOLs, in particular the implantable colamal lens. Now this is made of a polymer of porcine collagen and hydrophilic acrylic material, and this material is important because it attracts fibronectin and it is an immunologically inert material. Now it's inserted into the ciliary sulcus between the iris and the ciliary body. We'll look at some of the important criteria for implanting phakic IOLs. A stable manifest refraction, ametropia that is not correctable with excimer laser surgery, an adequate anterior chamber depth of around 2.8, preferably 3 millimeters, an adequate iridocorneal angle aperture, endothelial cell count, and no pre-existing ocular pathology. So the IOL power calculation is based on multiple nomograms, but mainly the Van der Heide nomogram for anterior chamber phakic IOLs and the Binkhorst nomogram for the posterior chamber phakic IOLs. Sizing is the absolute key for ICL implantation. Now sizing is based, the FDA approved method is wide to wide distance, and it is calculated based on so digital calipers are used preoperatively on a slit lamp, and the sulcus to sulcus distance is calculated from this wide to wide. However, the direct measurement of the sulcus to sulcus distance has also been debated, and that can be done with the help of ultrasound biomicroscopy, ASOCT, as well as Scheimpflug imaging. So this is a surgical video of ICL implantation. The most important step is loading the lens into the injector such that the correct side faces up, two side ports superiorly and inferiorly, a temporal main port. The chamber is formed with visco and the ICL is injected into the ciliary sulcus, allowed to symmetrically unfold. Visco is given to guide it along, and very gently the foot plates are positioned under the iris such that the optic is not damaged and the crystalline lens is not damaged, and a thorough irrigation is done for at least 2 minutes to remove the visco. Now in this is the Evo Vision ICL, and in this we can see a central 360 micron port. So this port is very important to ensure a physiological flow of aqueous and has been known to reduce the incident of cataract as well as post-op IOP rise. While smaller ports lead to inadequate drainage, larger ports can cause optical aberrations. So again, the importance of sizing cannot be overemphasized. Improper sizing is improper vaulting. Now a large vault will lead to chafing with pigment dispersion and angle closure, whereas a small vault will lead to cataract and ICL rotation. This is an anterior subcapsular cataract caused 18 months post-operatively. IOP rise post-op can be because of many reasons, but the most important reason is a pretrabecular block because of retained visco. The other mechanisms can be pupillary block because of an exaggerated lens vault and malignant glaucoma. The other symptoms are, the other complications are endothelial cell loss, IOL decentration and rotation, and nighttime symptoms like glare and halo. So the homework for the next class is multifocal phakic IOLs and bioptics. So thank you very much.
Please.
एक हैंडमाइक होगा तो दे देना ना.
I'll read up, ma'am. Ma'am, the multifocal IOLs are basically fake. The main disadvantage of phakic IOLs is the loss of accommodation. So if we can overcome this with the help of multifocal IOLs, then that would negate that particular. So right now, the care group is developing multifocal IOLs from a dioptric range of 1.5 to 4 diopters of presbyopic correction. So these patients will, they'll basically be able to accommodate, and it will simulate a more natural quality of vision. They have not yet come into the market, but they're underway.
Then it is speaking skills, content coverage. Time.
Yes, ma'am.
And answers to questions.
Okay, ma'am.
Thank you.
Yes.
So we
Thank you.
move on to the next. Dr. Veena Vishwam is here.
That's what.
Presenter. Who is going to present?
need for-
Dr. Veena is here. You are the mentor. Who is going to present?
Right.
But they said the judges were
Please come over. Presenters. Sri Lakshmi.
So we can go back to number 1, sir. Kasturi Bhattacharya.
Oh, yeah, no, to Abhi. Done. She was done, I think, right now.
Oh, no.
Abhi.
Okay.
Two has been done.
Oh, yes, yes.
Both of them will present.
Yeah.
No,
No.
one
Rutusha.
group, one
Rutusha is
person.
still yet to do. Yeah, come. Rutusha is yet. Rutusha
Who was the
Durbar.
first one?
Rutusha.
No, first one was
First
Rima,
one was
Dr. Rima.
Hitisha. Hitisha. Abhi.
Hitisha. She was Rima's student, no?
Yeah, she is at
Or
retinoblastoma. Who spoke on retinoblastoma? Hitisha. And Abha Gupta spoke on?
Good morning, students. Welcome to my class, and I'm Dr. Ritusha Dodwad. Today we are going to talk about the management of macular hole. In our previous class, we've already brushed up a little on what is a macular hole and why is it caused. So now we are going to discuss about the management of macular hole. What is a macular hole? Would anybody like to attempt the question here? Any students? It's a small gap in the retina at the level of the macula, and this is an OCT imaging. The second picture that we see is a normal OCT image of the normal macula. We have seen and diagnosed the macular hole on an OCT. But what is the slit lamp examination which will help us to diagnose the full thickness macular hole? It's a good question, right? I want you to go back home and read up on this and tell me the answer tomorrow. This is a very nice diagram depicting exactly why a macular hole and how a macular hole is caused. First, there is vitreous condensation above the macula. There is vitreous traction, and there is centrifugal pull and centrifugal traction, which leads to gaping of these retinal layers, leading to the loss of the retinal layers at the macula. Anyone would like to attempt a staging of macular hole? Any guesses of how it's graded? Okay, I'll help you there. Stage 1 is basically a yellow dot that we see at the macula, and on OCT it is the horizontal schisis of the retinal layers. In this case, we can always wait and watch. And we can also attempt another newer modality, which is the ochreplasmin injection. Ochreplasmin is a proteolytic enzyme. And how does it help us with the macular hole management if it's a proteolytic? Come on guys, be interactive. How does ochreplasmin help us? Yes, very good, excellent, smart kid. So anything beyond stage 2, which is a full thickness macular hole with or without a posterior vitreous detachment, we go ahead with the surgery. There are two main principles that we want to attempt with the surgery. First is to relieve all the tangential traction, that is either by removing the vitreous condensation, and second by the epiretinal membrane removal. And the second principle is to provide a retinal tamponade. We do it with the help of the gases, so that the anatomical apposition that we have attained with the surgery is maintained. Here we are attempting a 3-port pars plana vitrectomy, a 25 gauge. We are marking the port distance from the limbus at 4 millimeters in the phakic patient here. We do a core vitrectomy and stain the remnant vitreous with the help of triamcinolone acetonide. We see that around the disc there are white strands, and we are removing the posterior hyaloid attachment from posterior to the anterior and making the we are exposing the internal limiting membrane that we are supposed to stain next. How will we stain the internal limiting membrane? We use a brilliant blue dye here. Any other dyes we can use? Any other dyes we can use for staining the ILM? We use the ICG as well. So after staining the ILM, we can see that there is a blue color sheen. We are using a finish loop to scrape off from where the vessels are there, because the ILM is least adherent at that point. After the flap is obtained, the initial flap, we take a forceps and do a maculorhexis. What is a maculorhexis? Just like a capsulorhexis. We do a tangential traction, a maculorhexis, and we go 360-degree around it. Usually a 1.5 to 2 diopters maculorhexis is done here. We do not, beware, we do not pull it perpendicularly but tangentially. After we've achieved the maculorhexis, we do a fluid gas exchange, where we are maintaining the environment around the macular hole in a dehydrated state, and the apposition that we have attained of the macular hole gaping, we will tamponade it with the help of a C3F8 or an SF6 gas at the non-expansile concentration. As every surgery, there are a few complications here as well. First is the nuclear sclerotic cataract, a later reopening of the macular hole, a peripheral retinal break, and a wedge-shaped temporal visual field defect, very rarely though. There are certain challenging cases in a macular hole surgery, which is basically the macular hole is chronic, non-healing, size greater than 300 microns, and in these cases we have the advancements. I want you all to read up on advancements and come back in my next class, and anybody who does the 3 main advancements will get a Cadbury from me. Up for the challenge, guys? Yes, great. Thank you so much.
Very interesting presentation.
Thank you, sir.
What 2 important post-op advice that you like to give in a post-macular hole surgery?
Sir, if we are instilling the gas, we would ask the patient to lie in prone position for around 5 to 7 days, and the advice of...
hours in 24 hours?
No, sir, usually around 12 hours, but not over the whole 24-hour period. As much as the patient can tolerate, around 6 to 12 hours, sir.
What's second most important advice?
Sir, anything that induces Valsalva, or basically any strenuous exercises, we'll ask the patient to avoid.
Your patient has come from Jammu and Kashmir.
Air travel, sir. Air travel we'll ask him to avoid if we are instilling gas.
Very important that you have to strictly advise them not to travel where it is the gas.
Yes, sir.
Is there any difference if you injected air or you injected long-acting gases in air travel advice?
Sir, I think it is over the period of time that we can allow the air travel. So if it is air, then so I'm not very sure about this, but I think the...
What is the procedure to attend your class?
To attend, ma'am, it's free of cost.
So, Professor Rutusha,
Yes, sir.
probably you could have, Rutusha, yeah. Probably you could have mentioned something about the clinical aspects of examination
Of macular.
of a macular hole. Like we have the Allen-Wadsky test,
Yes, sir,
the
yes, sir.
laser beam test.
Yes, sir.
These you could have spent about 10-15 seconds on these before you started off with the OCT evaluation.
Yes. So that I wanted to give as a homework to the students, because that is a very handy test that everybody can use.
I know
So I
4
wanted...
minutes is too short to
Yes,
cover
sir.
everything, but I
Yes,
think
sir.
that's very important from the examination point of view.
Yes, sir, I agree.
Some examiners are still fond of asking these questions.
Yes, sir.
And octoplasmin is not used nowadays.
Yes, sir.
So I think we can avoid telling that to the students.
Okay, sir.
If any examiner asks what is the medical management of a macular hole stage 2, then we can probably mention about
Mention
octoplasmin. Otherwise, it is not used in the
Used
present
these
age,
days.
discontinued because of its toxicity.
I'll keep that in mind, sir.
Who's your mentor?
So Dr. Kasturi Bhattacharji, ma'am. Thank you.
You got a beautiful mentor. Gargi is presented, no? Abha. Abha. Judges are all confused only. Okay. Huh? All girls, yeah.
Both teachers and students all will be girls in ophthalmology.
See here also, no?
Yeah. So we have both presented.
Yeah.
Introduce yourself. You are Abha.
This is Ritusha Gagi, all the presented.
Start.
Good morning, everyone. So today we'll discuss a case of simple limbal epithelial transplant. Coming on to the basics first. It was first described by Sangwan et al. In 2012. Simple limbal epithelial transplant is a single-step surgical procedure to treat uniocular limbal stem cell deficiency, which is characterized by conjunctival epithelial ingrowth, persistent epithelial defect, chronic epithelial staining, and loss of transparency or integrity of the cornea. Coming on to the indications for slit, it is usually done in unilateral ocular chemical burns, contact lens induced limbal stem cell deficiency, and it is also used for ocular surface reconstruction in ocular surface cell neoplasia, primary or recurrent pterygium, post-topical mitomycin C use, and a laryngo-oncocutaneous syndrome. The contraindications mainly include diseases which have a bilateral involvement, like congenital limbal stem cell deficiency occurring in aniridia or xeroderma pigmentosum, autoimmune disorders like Stevens-Johnson syndrome or pemphigoid, any dry ocular surface with keratinization of cornea or conjunctiva with the Schirmer's less than 10 mm with anesthesia, any blind eye which does not have any visual potential, any disorganized anterior segment with extensive peripheral anterior synec or adherent glaucoma, any untreated adnexal pathology which includes lag of thalamus, like cryocystitis, trichiasis or entropion, as it will delay the corneal healing. Before coming on to the surgical steps, it is important that we know what patient preparation we need. It is important that we have a detailed history of the patient with detailed slit lamp examination. And if we have the technology, we should always go in for an anterior segment OCT to look in for the corneal thickness. The surgical steps are 3 steps. In the first, the donor site preparation, we have to do a 2 into 2 mm marking across the superior limbus. Now, why the superior limbus? Because it has the maximum amount of limbal stem cells in palisades of O, and it is also covered by the superior eyelid. Then there is a subconjunctival dissection, which is carried out 1 mm into the clear cornea, and the limbal tissue is excised and kept safely in a balanced salt solution. In the host site preparation, 360-degree peritomy is done and any fibrotic tissue is removed, but we leave the healthy corneal epithelium, and the bare ocular surface is covered with human amniotic membrane. Now, why human amniotic membrane is because it acts as scaffold for growth and is anti-angiogenic, anti-fibrotic, and anti-inflammatory. For the graft placement, we cut the donor limbal tissue into 8 to 10 pieces, and the graft is secured on the overlying amniotic membrane with fibrin glue, and a soft bandage contact lens is placed. Coming on to the post-operative care, the patient should always be started on preservative-free topical antibiotics and topical prednisolone phosphate 1%. The bandage contact lens can be kept up to 1 to 2 weeks depending on the healing of the patient, and the topical steroid should always be tapered after the removal of the bandage contact lens, and we are supposed to give a good amount of carboxymethylcellulose 0.5% eye drops. Coming on to the complications, it can be divided into recipient eye and donor eye complication. In the recipient eye, it can lead to hemorrhage under the amniotic membrane, any detachment of the amniotic membrane that can occur, early loss of stem cell transplant, sterile or infectious keratitis, any recurrence of conjunctivalization, symblepharon, and in the donor eye, it can lead to focal or non-progressive limbal stem cell deficiency, pyogenic granuloma, or even a subconjunctival hemorrhage. So the take-home message for this class is that the simple limbal epithelial transplant is a one-step procedure which does not require any surgical setup and is cost-effective. And also, since it is an autologous transplant, there is no need for immunosuppression. But we should keep in mind that the major indication to take up the patient for slit is that it should be done in uniocular disease pathology with a healthy contralateral eye. Thank you. And I would like to thank AIOS and my professor, Professor Reema Bansal, for guiding me through this class.
पूछ लो क्वेश्चंस आप योर एरिया ask the questions.
How the teaching could have been better? Or
Can you tell me anything about the indications based on the? Can you classify the limbal stem cell deficiency
It
and
can
which
be,
one which will be suited?
it can be congenital or acquired. In congenital, it can be like, it is usually bilateral, so we avoid slit, which includes PAX6 mutation, in which there is severe limbal stem cell deficiency in aniridia or xeroderma pigmentosum. In acquired, it can be bilateral or unilateral. Unilateral, in cases like the most common indication for which we do slit is the ocular burns, chemical burns, in which we present because it is unilateral and we can go forward with it. And also in cases like there is primary or recurrent pterygium, there are instances that there is localized limbal stem cell deficiency. So we can go forward with it. However, in systemic cases like Stevens-Johnson syndrome or any other autoimmune disorder, it is important that we thoroughly look at the contralateral eye. It might be unilateral in presentation, where we can go forward with the slit, but usually it is bilateral, so we try and avoid it in systemic cases of limbal stem cell deficiency.
What's the biggest hindrance to slit in clinical practice when you're counseling the patient?
Ma'am, the biggest threat is that we are actually taking a biopsy of the healthy eye of the patient. So it is important that we counsel the patient that yes, we will be taking a biopsy of the healthy eye, which is usually taxing. Yes, consent. Yes,
Often
ma'am.
you do not get consent for
Yes,
slit.
ma'am.
Yeah.
Just a suggestion, you could have added more pictures in the first introductory slides, because for students to understand later the surgery and all those procedures, you very well demonstrated it quite well. But in the initial where you're showing the indications, you could have added. So the visual impact is much better for the students.
Ma'am, I will keep this in mind, ma'am.
Yeah, thank you.
We call now Dr. Kalpit Shah. Thank you, Dr. Kalpit Shah, who is the mentor for
Good morning, class. So what is common for all these people on screen? Well, they have been hit by something with mass and acceleration on the eye, causing sudden deceleration, causing huge amount of force to be transferred on the eye and adnexa. This leads to huge amount of damage. This brings us to the topic of today's discussion, closed globe injuries. I'm Dr. Pawan Garde, mentored by Dr. Kalpit Shah. What are closed globe injuries? They are basically blunt trauma which causes injury without causing scleral rupture. What are the various settings in which it can occur? It can occur in sports injuries, it can occur during assaults, or it can occur during accidents. They are more commonly seen in males. What are the different mechanisms that can happen in closed globe injuries? Basically, first is the Coop mechanism, where there is a direct force impact on the structure. Counter Coop mechanism, in which there is pressure wave is transferred to the posterior pole, and ocular compression, in which there is sudden anterior posterior compression of the eye, causing lateral expansion, causing damage to the equatorial structures. Coming to examination, how do the patients present to you? The patient basically comes to you with a history of trauma, followed by pain, and which may be associated with sudden diminution of vision. So you take a detailed history. Always take a non-APR consent, or if it's a APR case, inform the police. Remember, koi bhi risk nahi lene ka. Then when you come to the examination, first things first, take vision. Vision, if the range can be from 6.6 to no PL, no matter what the vision is, you have to first do a slit lamp examination. Then you have to do the IOP measurement. If IOP measurement is normal, always dilate the patient and see the fundus. These three examinations are always mandatory for any blunt trauma injury. So what are the different things you can see in slit lamp examination? First, you can see conjunctival tears. If they are small enough, they can be managed conservatively. If they are large, they can be sutured. There can be conjunctival chemosis with subconjunctival hemorrhage. They may look scary, but can be managed conservatively. Then in cornea, you can have descemet membrane tears due to inelasticity of descemet membrane. Also, endothelial damage can cause corneal haze. Coming to anterior chamber, there can be hyphema. These are the various gradings of hyphema. These are very important Viva question. Please take a note. Hyphema can be if there is no subconjunctival hemorrhage around associated with it, it can be managed conservatively. If there is conjunctival chemosis and subconjunctival hemorrhage, always explore to look for any scleral ruptures. Hyphema can be left. You need constant vigilance when there is hyphema, because during 4 to 7 days there can be always a rebleed. Then post-trauma patient, when they come in follow-up, always look at the angle structures, because there can be angle recession which can be seen as irregular widening of the ciliary body band, or there can be also be ciliary cyclodialysis, in which the patient can present with ocular hypotomy. Then trauma to lens can cause traumatic cataract, which is rosette-shaped cataracts. Then there can be zonular dialysis, in which there will be lens subluxation. There can be IOL bag complications, in which there is IOL bag can be subluxated or can be into the vitreous cavity. Then there can be vitreous hemorrhage. Note on Terson syndrome, which is vitreous hemorrhage associated with subarachnoid hemorrhage. There can be retinal dialysis, retinal tears. Berlin's edema can be present. Traumatic macular holes are present. There is choroidal rupture, which requires observation only. Traumatic nerve avulsion is the most severe complication. Orbital fracture can also be present, which can have muscle entrapment. These are the various references, and thank you. Prevention is the main key, and these are the various resources that you can go. You can scan the QR code and you will get a Dropbox links to that.
So, Pawan, I think you should start off in a trauma lecture like this to the students. You should start off by saying any trauma should not be trivialized. However trivial it might appear, you should have a keen sense, index of suspicion for sight-threatening and life-threatening situation underlying. So this is one thing that you should start off with. So it may be just a black eye, but he might have sustained a head injury which will manifest 24 hours later, and he might end up in the ICU with a subdural hemorrhage. So this is something that you should start off with, and then you can go on to the rest of the examination. So please don't forget that.
Is radiological examination mandatory?
Yes, sir. In case if you are not able to, radiological examination can be local as well as.
Can be local. Patient comes with blood trauma.
Yes, sir.
Will you keenly advise radiological investigation?
Yes, sir. Because blood trauma, you can have head injury, and NCCT brain is mandatory. He can have a bleed which can progress to which he can have complications later.
I'm asking X-rays. Will you advise any X-ray in these patients?
Yes, sir.
And what do you look for?
Intraocular foreign body,
So you are,
and orbital fractures. Sir.
So you have blood trauma.
What about posterior scleral ruptures? You should have told the students how to identify it from a pure conjunctival hemorrhage, which is extending towards the temporal or nasal periphery. How to differentiate it from a posterior scleral rupture clinically. The eye would be soft, and the extent it goes further beyond, whereas a conjunctival hemorrhage could end at a particular location. So you have to mention, because these are small clinical signs which the student has to pick up when he's examining a patient.
The deep AC, the hyphema, the peaking of the pupil, the soft eye, all point towards an occult rupture. Could be posterior, which you cannot see. These are things, and you should also mention about the timeline of your examination, like what you will examine on day one and what you will examine, what will be the follow-up regimen, and what you will examine at each follow-up visit. These are things which are important from the practical point of view of management of the patient.
Actually, it was there, but it was not fitting in the.
Yeah.
So actually,
Also,
the
what you should avoid, no digital pressures and all that you have to also mention. Small key points which are important for a student to know.
Thank you, sir.
Okay, Namaskaram Kochi. So today I will be talking to you about two distinct and novel techniques of endothelial keratoplasty, named descemet membrane endothelial keratoplasty and pre-descemet endothelial keratoplasty. So I'll start the class off with a short story about this. So there was this ophthalmologist in Nottingham who, while performing lamellar dissection, noted that there was a distinct strand which was present between the stroma and endothelium, which he thought might be descemet membrane. But while performing the descemetodexis, the same strands were absent. So then they got curious and performed imaging and histopathological analysis, and they found that there sits a very distinct layer between stroma and descemet membrane, which we now know eponymously as the Duas layer. So what that gives you students is another short note to study about, but what that gives to surgeons is a perfect plane of separation between stroma and descemet membrane, and what that gives us is a way to find thinner grafts. So in descemet membrane endothelial keratoplasty, the grafts comprises of descemet and endothelium, whereas in pre-descemet endothelial keratoplasty, the grafts comprises of pre-descemet, descemet and endothelium. So now you might ask that why do we need these thinner grafts? We already had ultra thin DSEC, we already perfected that graft. But what was the problem with that? Was there was a tenacious thin layer of stroma that we could not get rid of. And why do we need to get rid of the stroma? Can anybody answer that? Why do we need to get rid of the stroma? Is because with thinner grafts, what we can have is better visual acuity, faster rate of improvement, and less chances of graft rejection. So what is importance of this thinner graft? Who will be benefited from this? So the indication of performing this endothelial keratoplasty is in patients who have to have optical corrections, like patients with ABK and PBK, pseudophakic aphakic bullous keratopathy, patients with Fuchs endothelial dystrophy, any other congenital and hereditary endothelial dystrophies, and patients with eye syndromes. So now, who will tell me how to perform this endothelial keratoplasties? Can anybody tell me? Okay. So it is easy to identify it histopathologically, but it is difficult to find it clinically. So what they did was they tried to perform pneumatic separation. They injected air into the cornea by endothelial, putting the donor graft endothelial side up. And when they injected the air with a 30G needle, they found that one type of bubble which formed from center to periphery, which was around 7 to 8 mm in size, and it was very well distinct compared to another bubble which formed from periphery to center, which was larger than the first bubble, and also it was very less distinct bubble. So if you perform the comparison, the first big bubble forms between stroma and pre-descemet, whereas the another big bubble that forms between pre-descemet and descemet. So they named it type 1 big bubble, which now gives us the pre-descemet endothelial keratoplasty graft, whereas the type 2 big bubble gives us the DMEC graft. So for preparation of the recipient, what we do is make a partial thickness definition depending on the size of the big bubble and also the indication of the keratoplasty. After performing that, the area that we delimited, up to that area we perform descemetorexis and remove the diseased endothelium and descemet membrane. After that, the graft is placed, whatever the graft we already prepared by the big bubble technique, we inject it with the clear corneal incision into the eye with a single use injector. And after that, we place the graft in the position with manual cannula and also putting the air bubble into anterior chamber. So this is the comparison between the two techniques. I already mentioned everything, the size and the characteristic. The only thing that I have to mention is the donor age and the type of procedure. So DMEC is a type of procedure which is tissue neutral. So whatever we are removing, we are only putting those tissues, descemet and endothelium. Whereas PDEK is minimally tissue additive because we are putting another layer which is pre-descemet endothelium, pre-descemet layer. And another thing is the donor age. So in DMEC, the donor age is dependent. So we only prefer the grafts which are more than 40 years. And one of you has to find out the reason why do we do that, okay? And PDEK is independent. In PDEK, what happens is we can use any type of graft, which any age. So it increases the donor pool virtually to very much. Okay, so this is the advantage of DSEC over PDEK and DMEC, which is technically easy and minimal tissue loss in easy graft unrolling, whereas DMEC and PDEK, they do not require any special instruments, there is no induced hyperopia, and there is partial visual recovery. I'd like to thank my mentors and okay, thank you so much.
That was a good presentation, and over to the experts, the corneal experts.
So you said that it's donor age dependent and you asked the class to find out the answer. Will you give the answer? Why?
So basically what happens in DMEC is that if we only have the endothelium and the descemet membrane. So when we try to unroll the graft in the cornea, it is very difficult for the young grafts to unroll because the endothelium and descemet membrane are sticky. But what the pre-descemet layer provides us is a stability. So the graft is...
I'm not talking about PDEK, just on DMEC. Why is it donor age dependent?
Because it is very difficult to unroll the...
Before that, peeling, preparing the graft, any issues?
Because endothelial cell loss which occurs because of...
Okay, do read up.
Dr. Sri Lakshmi Prashant.
Thank you all.
Thank you.
Good morning, students. Today
I want you to meet this amazing lady Leah who walked into our OPD some times back. Her problem was, in this cosmetically oriented world, her husband thinks she may scare their kids and she needs our help. So let's see how we can help Leah. As ophthalmologists, our area of interest is her eyes. So let's have a closer look of her eyes. At this point, I hope you all remember our last class about the contracted socket. So what do you see here? Yes, there is shortening of the lower phonics. So according to the Gopal Krishna classification system we have studied in the last class, this is grade 1 contracted socket or a mild contracted socket. Okay, so let's have a quick recap. In grade 2, there is shortening of both upper and the lower phonics. Grade 3, there is shortening of all the four phonics. And grade 4, there is shortening of all the four phonics with vertical and horizontal narrowing of the palpebral fissure. And grade 5 is a recurrent contracted socket post-reconstruction. So for the treatment of a contracted socket, our primary aim is to create a socket so as to maintain a prosthesis with good cosmetic appearance. So before socket reconstruction, we have to do a proper socket evaluation and take all the necessary precautions, then take a written informed consent from the patient and explain the prognosis to the patient very well. So in case of a grade 1 contracted socket with adequate phonics, then we have to just modify the prosthesis. In case of inadequate phonics, there can be shallowing of the phonics with or without fat prolapse. If there is shallowing of the phonics with fat prolapse, then we can do an open method of repair. And if there is only shallowing of phonics, like as in case of Leah, then we can do a closed method of repair. So there we put phonics forming sutures for deepening the phonesis. Then in case of moderate or a severe contracted socket, then we have to see if it is a moist socket or a dry socket. In case of a moist socket, then we do a mucous membrane graft, that is the gold standard. Here full thickness graft is preferred because it is less prone to contracture, and we can also go for a hard pellet graft or an amniotic membrane graft. In case of a split thickness dry socket, we can use a split thickness graft which is taken from the inner aspect of the thigh with a dermatome, and that is tied onto the socket. And if there is conjunctival and the volume deficit, then we go for a dermis fat graft. Okay, then here in recalcitrant cases, exenteration of the eyelid and the residual socket material is done to create a cavity into which the prosthesis can be fitted. So after this, when the socket is reconstructed and it is healed, then we can place a custom made eye prosthesis in that. So if nothing is possible, then there are optical methods to improve the appearance. You might think that this is a cutout piece of the eye, but no. Here, this is a prosthesis which can be mounted to a spectacle, and see the excellent result obtained in this patient. So at this point, you might be very curious how our Leah look after reconstruction. So here she is smiling with her beautiful eyes. So that's all for today's class. So before winding up the class, here is a video for my Pirates of Caribbean fans. So if you find Reggie somewhere, you just go and tell him that we have so many options for him. So that's all for today's class. And okay, one more thing, you have an assignment. Complete this and bring it in the next class. I'll share the slide in a WhatsApp group. Okay. So see you in the next class. Okay, bye.
Okay, teacher, we'll see you in the next class.
Yeah. Okay then. Thank you.
Anybody, any comments from
Any comments from any of the judges?
any oculoplasty people here who can
Any doubts, students?
judge on our behalf
Yes.
our teaching skills? Actually, she did very well.
Thank you, ma'am. Thank you.
Lakshmi.
Lakshmi Kumar.
Are you lazy? Or are your eyes? Good morning all. Today I'm going to teach you the recent advances in the management of amblyopia. In amblyopia, is the eyes which are lazy? No, it is a lazy brain rather than lazy eye. When you think about the treatment of amblyopia, the first thing that comes to our mind is patching. But Patching, like all other classical treatment, aims to improve the visual acuity of the amblyopic eye alone. The current concept is that amblyopia is a binocular disease rather than a uniocular disease. Then came the newer therapies like binocular therapy and perceptual learning, which aims to increase the binocular single vision in addition to the visual acuity. Now, what is this binocular therapy? Binocular therapy includes all the therapies in which both the eyes are used together. It includes dichoptic training. In dichoptic training, independent and visually different stimulus are given to each eye separately using anaglyph glass. This is an anaglyph glass. Here, high contrast image is given to the amblyopic eye and low contrast to the sound eye. And the patient can use both these images to view a full view of the image. This is the principle involved in all the dichoptic training methods, which includes the Digrash game, falling block game, dichoptic movies, virtual reality display, mobile apps and games, and interactive binocular therapy. Now let's see the Digrash game. Here, the gamer has to collect a goal in the card and a star point is earned. As the game progresses, the contrast of the sound eye is increased. But with unsuccessful 30 minutes of gameplay, the contrast is reduced. Same is with the falling block game also. Here, the blocks will be falling from top to bottom and the patient has to make a line with the help of these blocks. Next is orthoptic. It's a magnocellular pathway stimulator invented by our Indian doctor, Dr. Sandan Gopal. Here, 3 rows of white light will be seen, the center one being the red. The patient has to point with his laser to the light he is seeing. Same with the Occlupad or Occlutab, but done with an iPad and polarized glass. It has been said that children has got better adherence with this type of gaming. So visual acuity improvement is much more when compared with patching. Can you identify this legend? Yes, it's our legend Lionel Messi practicing and scoring. Practice makes a man perfect. This is what the perceptual learning is. Simple tasks are given to the patient and he is asked to repeat it again and again. The stimulus given are the Geber's patch, vernier acuity and the letter optotypes. But the study shows that there is not much improvement when compared with patching. But the advantage is that it shows some promising result with adult amblyopia therapy. Numerous trials are going on and let's hope that in future it may become the gold standard of treatment. Till then, the gold standard is our own patching. The cost of binocular therapy is also very high. So the question is it affordable to everyone? Now let's see what's new with the occlusion therapy. You have the liquid crystal glasses which changes from transparent to opaque. Occlusion dose monitor from which we can know the adherence to patching. And same is with Theramon, the temperature sensitive microsensor. Now we have the drug therapies, which includes levodopa, carbidopa, citicoline, citalopram and donepezil. Trials are also going on with this. So the take-home message is that it is a lazy brain rather than lazy eye. Amblyopia is a binocular condition rather than a uniocular condition, and our goal should be to improve the binocular single vision in addition to the visual acuity improvement. Hope all of you understand my class. Let's wind up then. Any doubts? See you all in the next class.
Shri Lakshmi, that was a good presentation. But don't forget the old when you're speaking about the new. You didn't mention about penalization.
Yes, ma'am.
Would you suggest penalization to anybody, or you would prefer all the newer techniques only?
First, we will try to correct the basic refractive error. Then after that, we can try patching or penalization. When it is not compliant with the patching therapy, whether any allergic to the patching, then we can go for penalization. Yes.
I'll pose you with a problem, okay? There is a child who is constantly on his tab mobile and doesn't listen to the parents. And this child, you want to give him some form of amblyopia exercises with video games.
Yes.
Okay. How will you go about it?
We can first basically we can correct the refractive error. Then after that, we can give the child interesting dichoptic games. That near vision activities will help to improve the amblyopia.
See, the problem is not that. The problem is the number of hours of usage.
1 hour or 2 hour can be given each day.
As I told you before, he's constantly on his mobile, on his laptop. Okay? Chance of myopia increases.
Yes, chance of myopia increases.
Also, the chance of digital eye strain, dry eyes, which starts many a times in children only nowadays. So, how will you manage that? Will you give something or some alternative to this?
We can give this binocular therapy.
Okay.
Thank you.
We must congratulate the mentor. I think your students are going to give you run for your money. Good presentation.
Thank you. Thank you.
Next is Dr. R. Sai Sunanda. Set of 2 students, Dr. Aishwarya Bhakta later. Or Dr. Sai Sunanda.
Good morning, class. Today we'll be studying about endonasal dacryocysto-rhinostomy. Okay, it means we're creating an opening between the lacrimal sac and the nasal cavity through the nasal approach. This was introduced by Caldwell back in 1893. However, the modern technique with and with the help of endoscopes was reported by McDonough and Mering in 1989. In whom do we do this surgery? In patients with nasolacrimal duct obstruction, be it congenital or acquired. Unlike external DCR, we can do this in case of acute dacryocystitis as well as lacrimal abscess. Okay. Obviously, we should know in whom we should not go for it. In patients with blood dyscrasias, lacrimal sac tumors, lacrimal sac rhinosporidiosis, and common canalicular stenosis. However, in patients with history of midfacial trauma, lacrimal sac diverticulum, and obstructive nasal pathologies like polyp are relative contraindication to it. Yeah, before going into any surgery, obviously we should know about anatomy. Let's say it. The lacrimal sac is located superiorly, anteriorly, and lateral to the middle turbinate. It extends about 10 mm above the axil of the middle turbinate and 4 mm below it. So our operative field is going to be in the middle meatus. Now coming to the maxillary line. It extends from the axil of the middle turbinate to the inferior turbinate. It corresponds to the social line between the thick bone maxilla and the thin bone lacrimal bone. So our aim is to create an easy bony ostium by exposing the thin bone. Now let's go into the surgery proper. It can be done under general as well as local anesthesia. However, general is more followed as we can control the intraoperative bleed. And patient is made to lie in reverse Trendelenburg position and surgeon always positions himself on the right side. Now, with the help of an endoscope, we'll examine the cavity and we'll decongestate with the help of xylometazoline. Now, the lateral nasal wall, anterior and superior to the middle turbinate, is infiltrated with the help of 2% xylocaine and 1:80,000 adrenaline. Now, using a 15 number blade, a vertical incision is made 10 mm anterior to the maxillary line and it is joined superiorly and inferiorly to the maxillary line. Now, using the Freer's elevator, we are elevating the mucoperiosteal flap until the lacrimal bone is exposed. Now, using the Kerrison's bone punch, we are doing the osteotomy. Now, first initially we are engaging the anterior lacrimal cusp and we are removing the bone until the entire lacrimal sac is exposed. And how will we confirm that this is the sac that is being exposed? With the help of probing. And this also tells us that we did the sufficient amount of osteotomy. Now, with the help of keratome or sickle knife, the lacrimal sac is incised vertically, okay, until the contents are drained out. And here you can see the pus coming out through the sac. And releasing cuts can be made with the help of Westcott scissors. Now, using a ball probe, the nasal mucosal flap and the posterior lacrimal sac flap are opposed edge to edge. This is to promote primary intention healing. Now, this can be achieved even without an endoscope, the non-endoscopic technique. But we'll be needing a 23 gauge vitrectomy light pipe, which is sent through the lower punctum into the lacrimal sac, and the transillumination is observed. Adjuvants like lacrimal stunting and antifibrotic agents like mitomycin C are in practice to decrease the chance of failure. So silicone tube prolapse, medial rectus injury, nasal mucosal adhesions are some of the complications you can come across. So now that you know about it, to brush your memory, you can go through this. Thank you. Any queries? Why not external DCR? Yes, external DCR in this world. Okay. Lacrimal sac is also our department. No? We can go for endonasal thing. Yes, the one thing is, in this world, many people prefer not to have a scar. We can go for a scarless surgery if it is an endonasal procedure. And the other thing is, in case of acute dacryocystitis and lacrimal abscess, if you go for an external DCR, it will leave you a fistula formation. The chance of forming a fistula and contracted scar is more when compared to endonasal one. Yes. However, the gold standard seems to be external DCR, but recent studies show that it's on par with external DCR.
Thank you.
Thank you.
So many Aishwaryas.
Hello. Start. Okay, so good morning class. Today we are going to discuss about posterior vitreous detachment or PVD. So what is vitreous? Vitreous is a gel-like substance present between the retina and the lens. Separation of the cortical vitreous from the ILM layer of the retina is known as the posterior vitreous detachment. Before knowing about PVD, we should know about the normal attachment of the vitreous. The strongest one being at the level of ora serrata, followed by optic disc margin, then the fovea, major blood vessel. The other sites of attachment are lattice degeneration, chorioretinal scars, etc. With age, there is liquefaction of the vitreous gel and condensation known as synchisis and syneresis. This leads to collapse of the vitreous and weakening of the vitreoretinal adhesion, resulting in PVD. PVD is a physiologic event directly related to age. The other risk factor associated with PVD are previous cataract surgery, PCR, yak capsulotomy, trauma, inflammatory condition like uveitis, myopia, syndromes like Stickler syndrome, retinitis pigmentosa, retinal laser, cryo, etc. Patients with PVD presents to us with symptoms like mobile, small, cobweb floaters, occasional flashes, or sometimes blurring of vision. On examination, we often find a Weiss ring, which is a glial tissue, indicates separation of the vitreous from the optic disc margin. We also need to look for any associated complication like vitreous hemorrhage, retinal tear or retinal detachment, vitreomacular traction, macular pucker, vitreopapillary traction, etc. B-scan is an important diagnostic tool which helps us differentiate PVD from retinal detachment, where PVD is a thin, smooth membrane, may or may not be attached to optic disc margin, shows good after movement, whereas RD is a thick folded membrane, always attached to optic disc margin, shows limited after movement. On A-scan, PVD shows less than 100% of spikes, but RD always shows 100% of spikes. OCT is an important diagnostic tool to stage the PVD. Stage 0 indicates no PVD. Stage 1 and 2 indicates perifoveal PVD with vitreous attached to fovea as well as the optic disc, where stage 3 indicates the vitreous is separated from the fovea, but it is still attached to optic disc. Stage 4 indicates complete PVD, where vitreous is separated from the optic disc as well. Mainstay of management is reassurance. We need to assure the patient that the symptoms will resolve on its own. We keep them in follow-up, in 6 months or 12 months of follow-up. We need to explain about the warning signs like increase in number of floaters, increase in frequency of flashes, decrease in vision or visual field defect to visit to an ophthalmologist. If the floaters are affecting quality of life, we can go for pars plana vitrectomy or drug assisted vitreolysis or Nd:YAG laser vitreolysis. If any associated complications are present, then we can intervene medically or surgically. Now we have seen the bad part of PVD. Let us see the good part of it too. Complete PVD prevents neovascularization. Surgical induction of PVD helps in managing refractile diabetic macular edema and relieving the vitreoretinal traction. These are the references. I want you to go back home and read up on this for further information. Thank you. Any doubts?
Your Aishwarya Bakri.
Yes, ma'am.
And who's your mentor? You're the mentor.
Was there any picture depicting the sites, common sites of firm adhesion of the vitreous to the retina?
Yes.
There was a picture. Okay, leave it.
Yes, the strongest one at the level of ora serrata, followed by optic disc margin. Then there is attachment to fovea and the major blood vessel. The pathological sites of attachment are the lattice degeneration, retinal tufts, cystic retinal tufts or zonular tractional tufts, chorioretinal scars. These are the pathological sites of firm adhesion.
You could have mentioned about the need for PVD induction during a surgical procedure in certain situations. In most situations.
Yes, sir. I mentioned about the benefit of it to relieve the diabetic macular edema retraction. Yes. There will be V's ring usually because the PVD starts perifoveally and then it gets detached from the arcuate vessels, then from the fovea and last to the optic disc margin. So we assume that if there is no attachment to the optic disc margin, then it is the post-equatorial attachments are lost. So it indicates usually complete PVD.
One more thing you could have mentioned was the B-scan finding
Yes, sir.
of a blood-layered PVD versus an RD.
I mentioned, sir.
Blood-layered PVD, which can be looking just like an RD, which would not have much movement.
Okay.
So that is one thing which could have been mentioned.
Okay.
That's okay. I mean, in 4 minutes, you have done your best. Good.
Thank you, sir.
Thank you very much.
Next will be Dr. Ayushi Gupta, followed by Dr. Sakshi Jain, both mentees of Dr. Rakesh Porwal.
When the first presenter is due to complete the question answer, the next should be ready. Short of time.
Good morning, students. So today we'll discuss about the recent advances in the management of myopia. Now, we all know what myopia is, right? It is the nearsightedness in which the parallel rays of light coming from infinity are focused in front of the retina. But why are we concerned so much about myopia? Because it is not just a cosmetic problem. It can lead to irreversible vision loss in the long run. Now, as you all can see the figures on the screen, myopia epidemic has become a major worldwide problem. And it has been estimated that by 2050, nearly 50% of the world's population would be myopic. And we all know that the COVID-19 pandemic has really added to this. So we need to control as well as prevent myopia. Now students, what are the myopia control strategies we know? We have the optical, the pharmacological and the surgical measures. Now the main cause of concern is the hyperopic defocus. And what is the solution to this problem? It is the myopic defocus. Now, what are the optical measures? The optical measures include the spectacles, the contact lenses and the orthokeratology. As the topic is the recent advances, so we will discuss only about the recent advances in spectacles. It can be the lenset or diffusion, and all these type of new lenses that you can see on your screen uses the lenset technology, and the one which uses the diffusion optic technology, it is the side glass vision. Now, I would like to ask you all, are you all comfortable with your glasses? I think many of us are not, but it is okay. Not everyone likes wearing glasses. But then, what is the other option that we have? Yes, we have the contact lenses. They provide you better cosmesis as well as good image quality. And one such lens is the Me Sight lenses, which are FDA approved, specifically designed daily disposable lenses for myopia control. Now think, what if our problem gets solved while we are sleeping and we have to do absolutely nothing about it? So here is orthokeratology.
in which hard contact lenses are worn during the night time and they provide you temporary myopia control during the daytime. But all these optical measures are not affordable by all. So one of the most effective intervention was that of atropine. Multiple studies, namely the ATOM 1, ATOM 2 and the LAMP studies have been performed, and very recently in India, the iATOM study by Dr. Rohit Saxena et al. Has showed higher efficacy of 0.1% atropine in the Indian cohort. Now, in what age group can you use atropine? You can use it in young children, usually 6 to 12 years of age group, and with a myopia of 1 to 6 diopters. But what is more important is the documented myopia progression of at least 0.5 diopters in the preceding year. We all know the lifestyle of today's generation. In decreased outdoor activity, increased near work has really added a lot to the myopia progression. Now, what is the screen time recommendation? Screen time recommendation according to various age groups have been recommended, and in school going children, it is less than 2 hours per day. Increased lifestyle modifications such as increased outdoor activity but only 2 hours per day and following various rules for limiting your screen time can help you prevent myopia progression. Now, I would like to ask you all, it is the total time spent outdoors or the physical activity? What according to you is more important? Well, according to the Sydney myopia study, it is the total time spent outdoors which is more important. We have read everything about the control and management, but how would you apply it according to age? So spectacles can be prescribed in all age group, contact lenses in young adults, and atropine in young children. But once myopia has come to a halt, adults need myopia management too. And the invention of femtosecond laser has really changed the scenario. So everyone, students, keep your eyes on myopia, and this is the theme for this year's Global Myopia Awareness Week. Thank you.
Ayushi, thank you so much. That was a nice paper. You did not mention about the MyKiddo spectacles, which are there recently now with the central aperture and which helps to reduce the peripheral defocus.
No, sir. Yes, ma'am.
Okay. Thank you. Sakshi Jain. Yeah, looks like uniform.
Good morning, dear students. I am Dr. Sakshi from Team Rajasthan. Today, we are going to discuss about one of difficult topic of ophthalmology, that is exudative retinal detachment and its management. There are ample of literature there, but I am here to make it simplify for this youth. Now, tell me, what is retinal detachment? It is fluid in potential subretinal space between RP and photoreceptor. According to etiology, it is of 3 types. If any break is present, it is rhegmatogenous. If any traction is present, it is tractional RD. And last but not the least, it is exudative retinal detachment, which is our main topic of concern. Exudative RD is collection of fluid in potential subretinal space due to breakdown of blood-retinal barrier, usually without any break and traction. These are the clinical features which all you are aware. Now, how would you approach it? For diagnosis of ERD, we need to ask about detailed history of the patient and ophthalmic examination. Ophthalmic examinations, which I usually prefer, are slit-leg examination, detailed fundus examination, ultrasonography, OCT. And fundus examination is the main tool for examining any retinal pathology. Now, history is done, ophthalmic examination is done. What is our next step? Our next step is to determine the type of RD, to differentiate it from other. ERD is characterized by SRF can be clear or turbid, smooth elevated retina, vitreous is clear or otherwise, and hallmark feature of ERD is volume and gravity dependence. We need to differentiate it from tractional RD, where concave border of retina is present, and from rhegmatogenous RD, where pigments are present in vitreous. Now, let's play Pictionary and know more about ERD with the help of case-based scenario. In first case, there is a picture which is showing disc edema and SRF over macula and SRF at supratemporal to the disc. We confirmed it with OCT, which is showing serous retinal detachment involving fovea. Now tell me, what is this? I think you need more information. Like patient is having multisystemic granulomatous disease, IOP is raised due to uveitis, visual acuity is decreased, KP and posterior cynic in slit lamp. Now we can conclude it is VKH. In other case, there is the fundus photo of a patient of type A personality which is showing NSD. We confirmed it by OCT, and in FFA there is a smokestack pattern. What is this? Yes, it is CSCR. In case 3, there is a patient of tuberculosis with history of malaise and fever. In fundus photography, we saw exudative RD and choroidal granuloma. We confirmed it with OCT and B scan, and there is a reduction in size after ATT. Now we can conclude it is granuloma ERD with tuberculosis. In other case, patient with decreased vision and retinal detached ERD with choroidal mass and history of squamous cell carcinoma. We confirmed it with B scan. There is a hyperechoic solid choroidal mass. In CT, chest and brain, there is a lung and brain metastasis. Now all these are suggestive of ERD with choroidal metastasis. Now, how would you treat this? Thumb rule is it is generally treated medically, unlike RRD and DRD. In medical management, our focus is on underlying causes, and in medical management, we give immunosuppressive like IV steroid, intravitreal triamcinolone, and other steroids like cyclosporine, azathioprine, and methotrexate. Other interventions are cryotherapy, focal laser photocoagulation, and pars plana vitrectomy. Better than 1,000 days of diligent study is one day with great teachers. Thanks to my all teacher, and I hope you would never miss a case of ERD in future. Thank you. Thank you, sir.
Thank you, Sakshi. Calling on
How's the energy levels in the morning? I hope it's high because today we'll be talking about one of the most interesting topics in ophthalmology, that is gene therapy. So let us start by defining what is gene therapy. It is basically the insertion of a gene into an individual's cells and tissues. Why? To treat a disease, particularly a hereditary disease in which a deleterious mutant allele is being replaced with a functional one. So before we move any further, we have to talk about the types of inheritance. We have autosomal recessive and we have autosomal dominant disease. In case of autosomal recessive disease, basically we have one gene which is being affected. Ma'am, the slides are like not working properly. Can I just reset? It's not working properly though. It's not changing. Change please. मैं लैपटॉप में कर देंगे. Can you restart the time? Okay. Good morning, students. How's the energy levels in the morning? I hope it's high because today we'll be talking about one of the most interesting topics in ophthalmology, that is gene therapy in ophthalmology. So let us start by defining what is gene therapy. It is basically the insertion of a gene into an individual's cells and tissues. Why? To treat a disease, particularly a hereditary disease in which a deleterious mutant allele is being replaced by a functional one. Before we move any further, we have to talk about the types of inheritance. Normally, we have two genes which produce two normal proteins. Suppose one gene is affected. At this point, one protein is produced, but the patient will be completely normal. Why? Because he's having another functional protein. Suppose in case of a recessive disease, both the genes are affected. Both the proteins are being affected. At this point, the patient will start showing symptoms. Here comes the role of gene therapy, where we put a new gene, a new protein, and the patient becomes completely normal. Mind you guys, in case of an autosomal dominant disease, we have a defective gene producing a defective protein. At this point, what happens? The defective protein will even convert the normal protein defective. And even if we give a gene therapy, that particular protein will also be affected, making everything completely defective. So what should we do over here? We have something called as the gene editing via CRISPR technology, where the defective protein is being destroyed, the defective gene is being destroyed, and as a result, the patient becomes completely normal. Now you guys will be like, sir, we have known something about the gene, but how to put this gene into the human beings? Via vectors. We have viral vectors and we have synthetic vectors. The most commonly used is the adeno-associated virus. Why? Because of its high expression, long duration, low immunogenicity, and low heterogeneity. Let me explain with the help of an example. So here basically I have a video in which a gene is put into the vector. This gene vector complex is being inserted into the retina. It divides into a single strand nucleus, a double strand nucleus, and finally it gets integrated into the host organism. Now, we cannot go and give this gene therapy to anything and everything. There are certain prerequisites. The genetics of the disease needs to be understood. The treatment should be efficient and non-toxic. And there should be a control of the gene expression. Sir, aren't there any issues associated with gene therapy? Yes, it is basically short-lived in nature. It can lead to multi-gene disorders. It can lead to immune responses and insertion mutagenesis. Then, why are we taking the eye? Because it is immunologically privileged. It has a defined volume. It has a closed compartment. And the effect of therapy can be monitored very, very easily. So, all these diseases can be treated with gene therapy, particularly retinitis pigmentosa and Leber's congenital amaurosis. And the scope in ophthalmology is way beyond retinal disease, corneal disease, and various other diseases. To all the students who are sleeping in my class, if there is one point that you should take home from my presentation, it is that the first internationally approved drug for gene therapy is Luxturna, that is vortigene neprivovic racil, in which an RPE65 gene is being inserted into an RPE65 associated retinal dystrophy. And we have various things. In case of wet ARMD, we have SFLT01 protein, which has anti-VEGF properties, and in case of dry ARMD, we have the CD59 molecule, which acts against the dry ARMD. Corneal graft rejection can be prevented by putting angiostatin and endostatin, which prevents corneal neovascularization. Also, gene therapy has promising roles in case of glaucoma, and the last but not the least is the color blindness, in which the L-opsin deficiency can be treated with the help of gene therapy. So, guys, what do you think are the future trends? Advances in the prenatal diagnosis, advances in the prenatal treatment, advances in the genetic counseling, and can we actually have genetically engineered anti-aging eyes? Thank you.
One thing you can rest assured, nobody is going to sleep in your class.
Thank you, sir.
Secondly, I think you can reduce your histrionics and body language a little. People should concentrate on the content rather than your body language. I think that's important. So it's okay. I mean, you did a good job in your enthusiasm, probably.
Yes.
You overacted.
But I have one thing to add, because
yes, ma'am,
something which is not very understood, you made people, you forced them to understand.
Okay.
Okay. Thank you.
Thank you, ma'am.
The next person is, and Ashish is the mentor.
Good morning, students. Hope you're enjoying the session here at AIOC. Since we're in Kerala, it's working here. It's working here. Can I just
Judge
restart?
in the next session, please. Judge in the next session. The last speaker.
Wait, I'll just change it. Good morning, students. Hope you're enjoying the sessions here at AIOC. Now, since we're in Kerala, let's talk about Kathakali, where eyes are the key for mastering it. And the beauty is binocular vision and binocular function. Similarly, when a patient with bilateral cataract comes to you, we need to preserve the binocular vision. Hence, today I, Dr. Ashmita Go, will be teaching you about the second eye cataract surgery. Let's see what are we going to learn in it. Why it's important, why is the surgery concerning, what is bilateral sequential eye surgery, and about a fun fact. It's important because it prevents anisometropia, amblyopia, better BSV, and increases visual field. A study by E.M. Talbot have shown that after the second eye surgery, there's an increase in simultaneous perception, fusion, stereopsis, acuity, contrast sensitivity, horizontal and vertical field of vision. Now, why is the surgery concerning? When a surgeon conducts any mistake in the first eye, he needs to rectify in the other eye. Why? To provide the best suggest uncorrected vision to the patient. Now, if a patient has IFIS in first eye, he needs to maintain the mydriasis in the second eye and prevent the iris from prolapsing by these intraoperative measures. Students, take a note of it. Okay? Now, if there's a PCR, these intraoperative measures should be followed. If there's subluxation of lens, keep the CTR in hand. If there's a PPC, do hydrodelineation and remember to make a 4.5 to 5.5 millimeter rexus. Now, if you keep multifocal, toric or tinted IOL in one eye, place a similar kind of IOL in the other eye. Okay? Now, what is bilateral sequential cataract surgery? It was popularized by Dr. Steve Ashdoff in 2008. It means that both the eye cataract surgery is done sequentially and it's two types, okay? Immediate and delayed. Now, when is immediate done? In patients having anesthesia complications and GA. In delayed, it's done most commonly in patients having within 4 to 7 days, and in patients having corneal pathologies, inaccurate biometries, lenticular abnormalities, high IOPs, and patients having cost constraints. The guidelines that's followed, that first this left eye OT will be done, followed by the right eye. Means you will see that the left eye dressing and draping is done, followed by the OT, and then he goes to the right eye. But before he conducts the right eye surgery, he needs to remember the surgeon has to change the gloves, the dressing should be done of the right eye, BSS, OVD and instrument tray has to be taken separately for the right eye. Okay, let's move forward. The advantage, most important, is quick rehabilitation and time and resource saving. And disadvantage is bilateral endophthalmitis, though the incidence have reduced. Now, by a study by Jonathan Malcolm have showed that the patients nowadays, if choice is given, prefer immediate sequential bilateral cataract surgery. And another, by very own J.S. Bhalla, a study is shown that in age of COVID-19, it has helped to decrease the surgical schedule and follow-up visits. And also, there's a significant benefit in reducing the infection exposure risk. Now, the pain perceived by the patient during the second eye surgery is much more, which might be due to the fact that the anxiety level during the second eye surgery is much less during the second eye surgery. Okay? Now, what's second eye syndrome? When a patient comes for the first eye cataract, it's a very new experience from him. But after the second eye, if he says that, I don't remember any of this from the last time, it's hilarious, right? What's that? That is second eye syndrome. Hence, I would like to conclude my class that if a patient to you comes with a bilateral cataract, please make them aware of immediate sequential bilateral cataract surgery. And you students should remember the conditions where it's contraindicated. Thank you.
Thank you, Asmita. I have got one comment for you and one question. Yes. The comment is that another place where you would do a bilateral, like simultaneous surgery, cataract surgery, would be with any patient having abnormalities of the spine and all, where you have to give special positioning to the patient with the microscope, but also keeping in mind the comfort level of the patient, because the patient should not get overtired, etc. So all these things would guide. And the question I have to you is that suppose by chance, when you planned a bilateral simultaneous surgery, if you have a problem in the first eye, would you go ahead with the second eye?
No, ma'am, then the concept of delayed simultaneous like sequential bilateral cataract surgery has come. I would not do.
I think your speed of talking has to be slightly less, 10% less, because some of the words we could not actually make. The diction is very important.
Okay, sir.
But the content was very good, but if you are not able to tell, the pronunciations and dictions are not optimum, then it can have a negative effect on your students. So I think that is something you should work on.
Thank you, sir.
No, I know the time is short, and you did a good job of kind of showing
Yes,
whatever
ma'am,
can
like
be done
then,
in a very
we had to,
high-speed
like,
fashion.
finish it by 4
That's
minutes.
all expected, but otherwise good presentation. Thank you.
And it was put forward as if like second surgery is a rectification for the person. So it is not like you gave it points were there, but it came across as that.
Ma'am, since that topic, like I had to make it why it's important.